My name is Julie Parsonette. I'm a professor of epidemiology and of medicine and infectious diseases. And as was mentioned, this was the last conference pre-COVID, and I'm hoping this is the first conference post-COVID, and that we won't have to be dealing with it too much more in the future, preventing things like this from happening. Dr. Wang's presentation reminded me that my first work on gastric cancer started more than 30 years ago, and on Helicobacter specifically, when a GI fellow that many of you may know, Tim Wang, who's a professor at Columbia, was a fellow with me. I was in ID, he was in GI, and he said, "What do you think of this Campylobacter pyloritis?" And I said, "Oh, I've never heard of it." And he said, "Well, they're saying it causes ulcer." And I said, "Oh, I'm sure it's nothing. I'm sure it's nothing." And so I spent the next 30 years working on it. My first paper on gastric cancer was in 1991. And my first paper in the gastric cancer screening and prevention was in 1998, I think, 1996, 1998. And since then, there have probably been tens of millions of people who have died of gastric cancer from an infection that is treatable, and it is really shocking to think of all those many, many people who have died. And probably the great majority of them were Asian. So I'm so grateful to see this meeting, and I'm very thankful to the organizers for pulling us together and reminding us that there is still a lot of work to be done. And I'm very excited to hear all the work that people are doing to get rid of this disease. So I'm sharing this moderation with Dr. Lautebaum, and we'll be introducing the speakers. Our first speaker is somebody, the last time I saw him was in Alaska, and at another conference looking at the same issue in Native Americans in Alaska. And Dr. Chin He, who's at Columbia, and he is going to talk to us today about approaches to modeling gastric cancer in the United States.
Back up.
This is a confidence monitor.
Okay.
So to advance the slides, you gotta use
I can't use the mouse.
okay.
I see. Okay. I'm looking at the wrong. I see. Okay. Well, thank you, Juha, Rob. Thanks for organizing. Julie, good to see you again. And Yuri's a good colleague as well. So I'm excited to be here. As I was joking with some others, with my people, so many good friends, colleagues from different gastric cancer pockets across the world. So just to follow up, 3 years ago, I remember I shared this story with some of you last 3 years ago. I was on the plane from New York to SF. And I checked my email. I dished out the Wi-Fi. I checked my email, and it was from the Dean of Columbia, and he said, lockdown, no more traveling to conferences. So I said, well, I'm in the plane, so I guess it's, that was the bookend to COVID. So it's so good to be back here after all the COVID situation, and it's so good to be in person. So it's a privilege to be here. So I'm going to speak on modeling. I need to advance. It's a little bit of a learning curve here. This is my disclosures. Nothing relevant to gastric cancer. Okay. In the 20 minutes, I'm going to talk. Okay. So, model, what is it and why is it useful? And I'm used to a little bit of skepticism about modeling. I think John Ndomi trained with Amnon Sonnenberg, who's one of the early, and his expression was model schmodel. Show me some real data. So I'm going to talk a little bit and put on my professor hat to medical students and talk a little bit about models, decision analytic models, and cost effectiveness. Then in a non-Western context, I'm going to go into examples of of modeling analysis in gastric cancer, just to highlight the point. And then I wanted to talk a little bit about the NCI SysNet Gastric Cancer Modeling Consortium and some of the stuff that we're trying to tackle, which I think dovetails with a lot of the efforts that we'll touch on in this conference. Okay, so I'm calling this modeling. This is, yeah, a little bit of a, I'm not used to talking, chewing gum, and advancing 2 slides at once, but Decision Analytic Models, Cost Effectiveness 101. And some of these slides are for medical students and fellows sometimes, but so why perform decision analysis and cost effectiveness? So yeah, for those who are older, remember EBV, randomized controlled trial quality of data. So traditionally, when we look at trial data or clinical evidence to guide our clinical and decision making, we look at traditional endpoints. And of course, life expectancy is the best endpoint. Death or prevention of death or survival is the hardest and best endpoint. And then in fields such as cancer, we talk about preventing cancer, cancer incidence, as well as preventing cancer recurrence, right? But you know, the world is a little more complex than that. We need additional endpoints or outcomes. A lot of this is we need a larger holistic picture. Okay, still working on chewing gum. Okay, so we need to incorporate other aspects, including quality of life, satisfaction with healthcare. Okay, so we need to incorporate other perspectives, not just a physician perspective, honestly. Patient perspective, so including quality of life factors, quality of care, health systems, healthcare facilities, and then also societal perspectives, including cost or economic burden. And I'll get to that. In the US, it's a little bit of a touchy issue. The randomized controlled trials are difficult because we need additional perspectives, not just life expectancy or cancer. So in order to do this, we need additional methodologic diversity. It not only are clinical trials, most decisions are not informed by clinical trials because they're not available, but we also need to capture these other endpoints. So next slide. Next, thank you. Okay, so advance. So this is not because I was in Boston for 20 years and everyone. Apparently, this young football player is a local. He grew up in San Mateo. And I'm not going to get into all the social stuff that's happening in their marriage. But you know, some people, when they hear model, they think supermodel. Okay, advance. They think a little, that's right, Juha was a biomedical engineer. They think an engineer, like an aerospace model for a wind tunnel to make sure the aerodynamics of the plane will fly. Next. Many people in our the wet lab, they think mouse model. So in the beginning, whenever I said model, my wet lab people think, where's the mouse? Okay, next. And for clinical research, when we say modeling, we're really thinking regression model, right? Databases, logistic regression, survival curves. So when we say modeling here, we're talking about a specific type of decision analytic model. Next. Okay, and since I'm at Stanford, next. The oft-quoted, essentially all models are wrong, but some are useful, right? So we just need to understand that models are what they are. They're not always 100%. And RCTs still are the gold standard of evidence. Next. Okay, that's the MAC transition. So there's different types of decision analytic models. Decision tree, that's the classic kind of, strategy A, strategy B, what are the outcomes, and do the emergent appendectomy, right? That's how we think. So Markov models have been around, that's recurring. Discrete event simulation, that's a standard operations research about how to optimize a commodity such as throughput through a clinic or organ donation. And then we do a lot of simulation, microsimulation modeling, and a lot of that is the microsimulation means that simulation means that we're actually modeling individual patients, not just a cohort or numbers, but that we're actually incorporating realism that way. And then agent-based modeling is gaining a lot of traction, especially with social media as in interactions between individuals, let's say purchasing in Facebook, but you can use this, for example, screening behavior. Okay, next. Okay, so depending on the reason we model is not just life expectancy, but we can project them out, but also incorporate quality of life, as well as costs, both direct costs related to cancer prevention and care, but also indirect costs such as loss of productivity to society. Next. Okay, next. So, you know, let me get out from the cloud and a little more concrete. It's one way. What's a decision analytic model? We're using a computer to simulate in one way, a clinical trial. But we can have as many arms in this clinical trial, an infinite number of patients, and infinite follow-up or until death. So it's a thought experiment, and the goal is to help guide a clinical decision. In a cost-effectiveness analysis, in the same vein, a lot of this is going to focus on informing policy, whether it be a third-party payer. Should we pay for this? And a lot of this is being able to analyze scenarios that aren't possible. Okay, next. All right, so yeah, this is really getting boring for many of you, but it's when is an intervention cost effective? It's trying to come up with analyzing whether an intervention such as a screening strategy is there value for money spent. So this is the endpoint of many of these cost effectiveness analysis. It's called the ICER, incremental cost effectiveness ratio, and it's the improvement in the difference in cost. How much is it going to cost more over how many life years are gained? And sometimes that can be quality adjusted. And that depends on who's paying. So for example, I was in Tunisia where we were talking about cancer screening there. One World Health Organization metric is you take the GDP per capita, and then it's either 1 to 3 times the GDP per capita. So for example, in the US, that's about 50,000 for one time and 150,000 for 3 times. So in the US, we use about $100,000 per life year gained. Next. So the US, next slide. So we're an outlier. This, the UK has NICE, where they try to calculate ICERs for everything and try to decide what should be funded based on the ICER. Their old metric was 20,000 pounds per life year. But in 2009, I believe it was Sarah Palin who termed death panels, cancer treatments not being covered. But it's not just Sarah Palin, and politics aside. I think many Americans chafe at the concept of cancer care not being covered. So, but we are a little bit of an outlier. And so, for example, PCORI, we have Dr. Koh, who is part of Obamacare. But the ACA, it's written in the creation of PCORI that cost effectiveness will not be included as a metric. USPSTF, they can look at costs, but they're in their recommendations, they do not include cost effectiveness. So we're a little bit of an outlier. But we can model. For example, USPSTF in colon cancer screening, they will look at colonoscopies per cancer and avoid this metric. So modeling can still be useful. We just look at different endpoints. Next. Okay, so this is the spectrum, and more complex models aren't better. So next. So simple models have the advantage of being transparent, but frequently it's an oversimplification. Next. More complex models can be more clinically realistic. You can put in all the bells and whistles of what actually happens to a patient, but next. But then you get the whole black box. What did you put in? Bad data? Can we trust what happened in the model? And these are very legitimate concerns about biases and about the uncertainty of the model results, especially when there's a black box. Next. Okay, so I'm going to give 4 examples. The first examples of published gastric cancer after my taking off the 101. Next. Chihu, how are we doing on time? Are we okay? I'm only about 1/10 through, so no, just kidding. Okay, so this is a shout out to Dr. Parsonette. Where's Julie? All right, there you are. And I don't think Dr. Owens is here. Is he?
He's coming later.
Okay. So this was published in 1996, and I got Julie's permission. And don't worry, whoever's speaking about HP screening later, I'm not going to get too much into this, but Julie had the answer 26 years ago. So she and Doug built this Markov model, and they did it on paper because there were no computers back then. And they compared HP test and treat versus no screen and no treat at age 50 in the US in higher risk populations. And I love, so what they found was it can be cost effective for mass screen and treat, but particularly among African Americans and Japanese Americans. And that's what that graph shows. But I love the conclusion. This is taken straight out. Screening potentially is cost effective, particularly in high-risk populations. Cancer prevention trials are strongly recommended. So this is 26 years ago. It hasn't happened yet, has it? All right, next. Okay, so this is something that one of my fellows, Judy, and then Monica's on there. Costanza. Is Costanza here yet? Okay, shout out. Hi, Costanza. So we did this thought experiment. This is very, very thought experiment-ish. So the biggest dietary risk factor for gastric cancer is salt. And that's the common thread between Japanese and Korean American diet, perhaps. I mean, Japanese and Korean diet. So what we did was, there's a lot of US trial data about the DASH diet to lower hypertension and cardiovascular risk. So we did this thought experiment. What if we started everyone in the US on the DASH diet? How much gastric cancer could we prevent? Now, this is unrealistic, that everyone would stay on this awful diet, honestly. But we found that we could reduce up to 20 to 25% gastric cancer risk and deaths. The problem was, at the end, the bottom is the incremental cost effectiveness ratio. For men, because it's a higher risk, it's about 300,000, 290,000, and for women, it's about 424,000. So, and the reason the cost was so high was gastric cancer rates aren't super high, but it's also because the cost of the DASH diet is quite high. It's like a pre-packaged, low-salt diet. But part of this is, we're not necessarily espousing everyone go on the DASH diet, but kind of raising public awareness that high sodium is a significant issue. Next. Okay, so in this third analysis, this is Jennifer Ye, whom I've worked with for a while. Her PhD at Harvard School of Public Health was building this gastric cancer model. And a lot of it, she spent 5 years. I was also on the clinical side of this, building this somewhat complex model that, and I'll get into that in the next analysis. But this is a paper that was very clinical. I think, is Dr. Kuiper here, Ernst Kuiper? So. Okay, he's not here yet, but he had published this, he was the editor of Gut, and he had published this thing about how we in the US surveil Barrett's, which is IM of the esophagus, but we don't do IM of the gastric cancer. So this was spawned by then. And the biomarker, we did this about 8 years ago. This biomarker, no, is not liquid biopsy. It's actually serum pepsinogen. So what we did was we did this thought experiment about screening and risk stratifying with serum pepsinogen, and also integrating EMR, ESD to see as that could improve the cost effectiveness. Next. And overall, we found that particularly, this is stratified. The left 4 bars are serum pepsinogen screening, endoscopic screening, and H. pylori screening, and particularly for people who are high risk, such as smokers, men who are smokers, that there could be significant benefit. I'm not going to go into the details of this, but next. Okay, now this is a very policy-oriented type analysis, and this is leveraging Jen Ye's pretty complex model. And so in order to do this, she wanted to analyze what's the contribution of HP and smoking to gastric cancer. And then she also wanted to make projections, particularly about smoking interventions and how it might impact future gastric cancer risk. So next. So this is continuing on her PhD. So in order to analyze past trends in order to make future trends, this is frequently what we do in CISNET models. We build birth cohorts to try to reproduce temporal or secular trends. Next. And so she took NHANES data and estimated trends in H. pylori smoking, and then tried to use her state transition model or her population level model to estimate how much of the attribution of current smoking gastric cancer decline is related to those. And overall, it was about 50%. It's hard to see this curve. And then on the right, it's hard to see that blue at the bottom, but that's if you had 100% smoking cessation, how you could bend the curve of future gastric cancer incidence. So this is a relatively complex policy level model. Next. So coming back to this slide, you've seen the range like that. Actually, that salt reduction, that thought experiment, was a simple model, whereas the attribution of smoking was a complex model. But depending on what you're trying to get at, in order to try to at least come up with quantitative numbers, you might need varying levels of complexity. Next. In order to address the black box, the NCI has sponsored a consortium of models that were for specific cancers for over the last 22 years, and it's called CISNET. And myself and a lot of people here in this room are part of the gastric cancer group. And a key component of it is comparative modeling. Because modeling has so much potential biases and uncertainty, each of the CISNET groups have 3 independent modeling groups, and hence the term comparative modeling. Next. So, in 2000, the big 4 cancers, colon, lung, breast, prostate. John and I were fortunate to be added in 2010. We've been working on the esophageal cancer model for 12 years. Cervix was added in 2015, and then 2021, just a year ago, they added gastric cancer along with uterine, bladder, and multiple myeloma. Next. So in the last few minutes, I'll go quickly through some of CISNET and the gastric cancer group. So I'm going to skip this. Keep going. So this is the esophageal cancer group. John is part of the UW-Miscan lower left. This is an old slide. This is when I was at Mass General on the upper right. So what we do is we all try to reproduce SEER targets over calendar year secular trends, and we compare. And because the modeling structures are different, we're not going to get perfect fits. But it provides a diversity of models, especially since we're making recommendations about policy. Next. And so when the 3 different colors, the black is the actual SEER esophageal cancer incidence trends. And then when we try to project, we just extended what we thought was happening with the trends. And for example, the blue is MGH, or now the Columbia model, and the green is John's model. And when we published this 10 years ago, when we followed it out, our model was the best. But next. So this is the gastric cancer group that just started. We have 3 different modeling sites, including, next. All right, upper left is the Harvard model. So it turns out, Fernando, are you here? Fernando's not here yet. I think he's giving a talk. So Fernando was in Mexico, but he just moved to Stanford. So he's with the Harvard modeling group, but he's actually with the Stanford group on the upper left. So that's Yuri Ladebaum and Rob. Rob just joined this, and that's the Miscan model. That's the Miscan modeling group in Rotterdam at Erasmus University has been doing a lot of cancer modeling. So that's the second group. And then the third group, lower right, that's me with some people at Columbia, and Monica and her group are working together on the GCMO, the gastric cancer simulation model. And then there's a SOT in the middle, including our NCI scientists and project support. So next. So we're trying to, big picture, what are we trying to accomplish with this U01 over the next 5 years? Identify high risks to target for gastric cancer prevention, and to also address disparities. As we know, gastric cancer really is a disparity cancer. Next. Next. All right, so AIM-1, we're still working on this. We're trying to develop models to estimate outcomes by race and ethnicity. Sometimes there's sparse data even in the SEER data, but we're trying to build comprehensive models that reproduce that. And then AIM-2, we're starting to do this with literature review and preparing the models to assess the impact of risk factor trends and primary prevention strategies. So a lot of this will be focused on H. pylori, obviously. Next, in AIM-3 and 4, secondary prevention, that includes endoscopic screening and surveillance, serum pepsinogen. And then finally, AIM-4, we're pretty excited about. Next, Monica made this killer figure for us that summarizes the entire project. For those of you grant writing students, you need a killer figure like this to get funded. Next. So I'm not going to go through all the details of what we do, but part of the reason I wanted to bring this up is we model, we don't do primary data analysis. If there are opportunities we would welcome people working with us to model outcomes. Next. So I'm not going to get into this. Next. Specific AIM-2, this is a shout out to Fernando. Fernando is the man behind the HP history generator, where he's taking prevalence trends of Helicobacter pylori because it's such a big risk factor for gastric cancer. And he's building a dynamic transmission model that incorporates population prevalences as well as antibiotic resistance. And then what we're going to do is plug that into each of our respective models as we simulate individual patients in the future. Next. AIM-3 is the GIs will be happy. Next. AIM-3, we're focusing on surveillance strategies and also trying to look at early onset, serum pepsinogen, and upper endoscopy. Next, and we're really excited about AIM-4. It's a little bit ways off, but after we calibrate our U.S. model, we have a agreement with IARC, and we want to make simple versions of our model available for countries that want to assess things like Helicobacter pylori, HP test and treat. Next. That's me and my daughter at a Columbia raised cancer awareness and research funds, and we were one of the two riders for Team Gastric Cancer. So next. All right, we'll take questions at the end. Thank you so much for your attention.